Hey, everybody. Welcome back to the You're Not Broken podcast. Super excited to have my friend Dr. Josh Gonzalez on the podcast today. He is a board certified and fellowship trained urologist and a sexual medicine specialist. He practices in the West Hollywood neighborhood of Los Angeles, helps all genders, and he's really good at everything he does. Welcome, Josh.
Hey, glad to be here. Thank you for having me, Kelly.
I feel like I met you on Instagram before I met you in real life.
I know, as many relationships form.
Yeah. Like, you're like, that's how the world works now.
Yeah, like how did doctors meet before Instagram? You know what I mean? Like I feel like I only know urologists through Instagram, and then I meet them in the real world. But
right?
yeah.
I know. Well, because people are like, do you have a card? Just this week, I was doing an event, and they're like, do you have a card? And I'm like, do you have Instagram?
Right. Yeah. Just tap my phone. It should do it for
I'm
me.
like,
Yeah.
do I need a card? I don't
Yeah.
know. I first met you at Ishwish. In my head, we met at like the snack line during coffee, which is where I tend to meet people.
Yeah.
So today we're going to talk about all things sexual. We haven't talked about sex on the podcast in like a solid month, so I'm like reveling in the opportunity. It's been hormone heavy, and we're going to do like hormone and sex adjacent conversation.
Love it.
I want to start with asking you a question, which is serious and not serious. But what is your what's your preferred word for penis?
In the office or with my friends?
Yes.
I would say cock is just
oh my god,
classic. Like, just really gets your attention.
Does
when you hear that,
does it feel good?
It does. It feels powerful. You know what I mean?
Okay.
Yeah.
Good. I get a little cringy with cock.
Oh, really? No,
Yeah,
I think I like
crass.
the hard sounding. It does sound crass, for sure.
But that's the point.
Sure.
The point is that it's crass. Like, it's in your face, and if you can't handle it, that's on you.
That's right. I also would not use that word in my office, but I think I have said dick before. If it's somebody that I have like seen for a long period of time, and we have kind of a more casual relationship, and they're being vulnerable and honest with me about stuff, sometimes I think it helps disarm people a little bit.
If they're using the word.
Yeah, exactly. Yeah, exactly.
I'm very clinical. Like my mom, like I grew up, it was always a penis, it was always a vagina, it was always a rectum. Like, it was very medically accurate and in a non-medical family. So like I just grew up with that. And so in the clinic, definitely medically accurate, but now I'm doing more stage work and crowd work. And I'm like making dick jokes on stage now.
I love it. Yeah, I mean, I think when you step outside of or step out of the white coat, let's just say, right? And you are an influencer, a creator, a thought leader in these spaces, and you're speaking to non-doctors, I think it helps people feel more comfortable, right? They're hearing you use language that they hear in their everyday life. So.
Yeah, totally. Yeah. And I mean, I know people didn't grow up always the way I grew up, where it's like, those are your private parts. We're going to use your urethra, right? Like, not everybody grows up with that.
Right.
So you did urology residency, and then you're one of the how many people now who've done the Dr. Erwin Goldstein fellowship? Crazy.
Well, I was one of the first Goldstein fellows after they moved to the West Coast. So there was Brian, I think, before me, and then Seth Cohen. And then I did my fellowship 2014 to 2015. And then there's just been it's like he has 12 adopted kids now. It's so crazy. We have a whole family of Goldstein fellows, which is really great.
Oh, so adorable.
Yeah, because it was a small group of us when I first started. So and now it's so big. We have our own lunches at these sexual medicine conferences.
That's so awesome. And for a while now, it's I think one of two female sexual fellowships in the country. Sarah Signa just started one, but it's very unique in its training. Can you talk about why you picked it?
Yeah, so I picked it because I fell in love with Erwin, to be honest. As you can attest to in urology, we do nothing related to women's sexual health at all. And so when I was applying to all of the andrology fellowships, and that was listed under the SMSNA with the other andrology fellowships. So I applied to all of them, interviewed at all of them, came to San Diego, really fell in love with Erwin and his whole practice model, and one of the first things he said to me on the interview was like, "Are you okay doing women?" And I was like, sure. And he's like, "'Cause that's a really..."
Did you know before that
I knew that he did his was sexual medicine, not andrology, and so I had some sense that he saw female patients. Did I have any clue what female sexual health meant? No. Like, I had no idea what the day in, day out of that meant.
Yeah. Because the gynecologists were supposed to be taking care of all of this.
Exactly.
Like, that's how we were trained, right?
That's right. That's right. Yeah. So I went to the interview and spent, I think, like 2 days with him, and just like fell in love with him as a person, and like how charismatic he was, and kind of mad science-y brain that he has. And I wanted to be back in California. And so I just basically like bugged the shit out of him and kept emailing him and was like, "I need to come to your fellowship. I need to come here. Please, please choose me." So I felt very fortunate that he did. Yeah.
It's so good when you're like hounding pays off. You're like, huh. You're either going to think I'm crazy for the rest of my life, or like it's going to work.
Right. Exactly. Exactly.
Okay. And so now you practice in LA.
Mm-hmm. Yeah.
And what was your biggest surprise when learning how to take care of female sexual health?
I mean, I think learning the anatomy, which is crazy, right? Because if we go through the medical education system, we do a full year of anatomy lab, right, in medical school. And I didn't think there was any other anatomy that we needed to learn, but turns out, we don't get taught about female anatomy. So I think, learning about that, learning about the various conditions that can affect women, that I had never heard about dyspareunia. I mean, not that I can remember. I don't ever remember hearing about women having pain with sex, like in residency in medical school at all. The only exposure I had really to female sexual health and urology was usually related to things like incontinence, right? Mm-hmm. That's the only time it really ever came up in my training. And so I think learning the anatomy, the nomenclature, and the various conditions that can affect, women's sexual health was, it was a steep learning curve, but Erwin sees a lot of female patients, and so it was very quick that I kind of got on board with that.
Yeah, I mean, you already spoke the language of pelvic health,
exactly.
And a lot of the treatments that we use in any gender is the same, as far as like, for example, testosterone, right, or hormones. We use some Viagra in women. We use Addy in men. Like, it's really as much as these things are put in little gender buckets, like you can really use them in a lot of people.
I mean, but like even the testosterone thing though, like, right, I like most people in the world understood testosterone to be a male hormone until I went through that fellowship, right, and learned about the importance of testosterone in female bodies, right? So I didn't learn that.
I didn't learn any of that in med school or residency. It was only through like discovering sex med and then discovering menopause. That, like the big aha for me was like, okay, yeah, ovaries make testosterone. I get that. But then like women have 4 times the amount of testosterone than estrogen when they're cycling and having periods. That for me was like what the fuck is happening?
Right. Why are we not talking about this?
Yeah. I mean, people are like, just giving women testosterone's dangerous. Giving women testosterone's illegal. Like all the things people say, I'm like, 4 times the amount of estrogen than estrogen.
I know. That's
4
crazy.
times the amount than estrogen. Just 1/10 the amount of men. That was the big. For people who don't know what dyspareunia is, it's pain with sex. I learned this in this is a little crass, but since we've already said cock, we're probably fine. I remember in residency, somebody was joking, like, it's better to dysparune, which means pain, with penetration, basically. So it's better to dysparune than not parune at all. And I think about that now, and I'm like, this is kind of rude and kind of crass.
Yeah.
But parune is kind of just a fun word. So I think we're just looking for an opportunity to say that word. But yeah, it's not a very nice. It's not a very nice thing to say, actually.
No. And I think a lot of people, we're joking about it here, but unfortunately, a lot of people are told that.
Yes.
Or believe it to be true, right?
Yes.
Like, well, I might as well just grin and bear it because this is the only way I can have sex. And how is this going to affect my relationship if I don't do that, right? So I think a lot of women, unfortunately, end up being told or believe that.
I think they're told that a lot. I think the use it or lose it myth is not a myth for a lot of people, right? There's like, if I just keep doing this, it'll eventually get better, and it's like the data doesn't support that unless you're getting help for it. Yeah, it's kind of like telling a guy with erectile dysfunction, just keep trying to have sex and your dick will get harder. Of like, that's not how it works. I haven't seen enough data. Like, use it or lose it. Ugh. But I was actually just looking at this like today. There was a paper in 2024 looking at vibrators for female, and it was non-penetrative. It was just external genitalia, vibrators, 5 to 10 minutes, 3 days a week. And their pain scores didn't change significantly, but the rest of the female sexual dysfunction did improve a lot.
Was that Alexandra's data from Cedars? Yeah. Okay.
Yeah. And so I'm like, okay, this is my asterisk in me. Like, I'm very protective of women. So I get pretty like, don't tell them use it or lose it, in the sense of like, put a penis in there and it'll change your hormones. But I'm like, dude, there is some data for blood flow.
Yeah. Yeah. And I mean, I think the panel that I was telling you about earlier, that I was a part of last night, we were talking about that, like breaking down even the idea of only having sex only being one thing, right? So like we need to decouple sex from intercourse, right? There are other ways to create intimacy, to have sex. Anything can really be sex. And so, if someone is incapable of having penetration, let's start talking about other ways that they can have a fulfilling sex life too.
People feel so broken when they can't put a hard penis in a wet vagina. Because that's all sex is. That's all Hollywood tells you sex is. That's all doctors really tell you sex is. That's all like the music industry tells you sex is, right? Like, it's, you literally know nothing different than that. And people are devastated because the only thing they ever knew as sex is being threatened.
Well, let me take that one step further. I think that extends even to the queer community. Like, I think, there are plenty of men who would like to be able to top and penetrate their partner, but have some degree of erectile dysfunction and just resign themselves to being a receptive bottoming partner because they're ashamed about it. They haven't sought help or whatever. And so, and they think those are the only two roles I can exist in, right? That's the only type of sex we can have. We have to have anal sex. So I think there's a stigma culturally, that we've created about like hard penis inserting into a hole. Yeah.
Totally. Again, people will give like the queer and gay community more credit than the heterosexual, to be like, hey, they're more expansive on what sex is. But I think what you're saying is like, hey, they get narrowed into stereotypes of like what it needs to be too. Nobody's like immune to it. This is a physiology question. Maybe there's data or not. Do you need a harder penis to do anal sex than vaginal sex? Like, is it because the sphincter's there? Like,
so I tell my patients that, going back to like the Viagra erection hardness scale, right, from the 90s during the initial Viagra trials, created by Irwin, right? A grade 4 erection is like the perfect erection, perfectly rigid, able to penetrate, right? That's the goal for everyone when you are talking about treating erectile dysfunction.
Okay.
I don't believe there's any data specifically looking at like the pressure exerted on the penis from anal sex like they did in those trials back in the 90s. But I would always talk to Irwin about this, and he would agree with me that the pressure that is exerted on the penis from anal penetration is much greater because there's not as much laxity. So I always tell my patients that, our goal with you is not going to be a 4. We need a 4+, right? To get you hard enough to be able to penetrate anally.
Yeah. I think there'd be patients who are like, hey, my penis is hard, who have pleasure with both vaginas and anuses, that can would say like, yeah, vagina's fine, but it's not hard enough to do anal sex.
Yeah.
Interesting. More research to follow. tell me, I know, one thing that's unique to you, one thing that's unique to Dr. Maria Yoloko, who I also love, is really the focus on treating the couple and not just addressing like the person in the room, but treating the couple as a sexual unit, or, plural, however many people are involved. But can you speak a little more? Because I think it's a newer concept, especially in urology, to consider the couple as a sexual unit instead of just taking care of one person's sexual needs.
Yeah, I mean, I think that's one of the beauties of having gone through the Goldstein Fellowship, is that we have the skill set to do that, right? Especially if we're talking about, heterosexual couples, and it makes so much sense. I would hope that going forward, it won't be such a foreign concept, because, people don't exist in vacuums when you're talking about their sexual health, right? They're often part of a couple, or in several sexual or romantic relationships at one time. And oftentimes, if you are not, you can help treat your individual patient, but if you don't understand the context in which they are having sex and maybe how that has affected their partner, there may be intimacy issues that don't get resolved, even though you've fixed the physiological problem that, they initially presented with. So, we see this all the time in men who have erectile dysfunction. We provide them some solution, either pills or injections or surgery, to help them get a rigid erection. And then they go to have sex with their female partner, who maybe is menopausal and they haven't had intercourse for years and is having problems with lubrication, and can't have penetrative sex. And now you've created this imbalance where one partner has resolved their issue and is motivated and wants to have sex, and the other partner is not capable of doing that. And so you can create a lot of relationship problems if you don't address that other aspect.
Yeah, totally. I mean, I the joke, because it was dealt with as a joke in residency, is like to laugh at we had women return Viagra prescriptions to the clinic. And we would laugh at it and be like, ha ha, shit. And like, not once thinking of, because I didn't do female sexual health in residency, right? Of like thinking like, oh, they probably didn't talk about this, and nobody's taking care of her. And really how unique people are, me, because I have the urology background and sex med, and like you and Maria, and like, to be able to see all genders is actually a very small piece of because the gynecologists don't take care of the men. I'd say most urologists who deal in Viagra don't take care of a lot of vulva owners. Like, it's actually pretty darn unique to be able to take care of the sexual couple.
Yeah. And I think a lot of that is, individual providers being motivated to do that, right? I mean, again, I only got this training in fellowship because it's something that I sought out, but, it's certainly not part of our standard education.
I joke, like, when I'm doing my stage stuff, I joke, like, for better or for worse, when men come to see me for Viagra now, I've got the female sexual med training, because I'm like, what's your plan with the super dick? Like,
right.
And
have you talked to your partner about this?
And I mean, I was actually really shocked by the high percentage of people who had not talked to their partner about it. What do you find?
I think that's probably pretty accurate. I'm always surprised at how many treatments some of my male patients come in requesting or needing when they haven't had a conversation with their partner, right? It's like they probably know that you have ED. I mean, like they're
aware you have not been sexual with them.
Right, exactly. Yep. So you're just going to wake up one day and be like, all right, we're ready to go. You know what I mean? Like, they're going to be like, what's going on? Yeah. I mean, I remember in residency, it's been a while since I've seen this, but I remember clearly in residency, several cases of men who underwent penile implant surgery and did not tell their partners.
Yep.
Oh, I'm having hernia surgery was the big excuse. And to me, I was just like, I mean, I guess that's your prerogative. It's it's
your body autonomy.
Exactly.
Yeah.
But you are also having sex with this other person. How are you going to navigate this? And do you think that they're just gonna think that you magically fix the problem out of nowhere?
Right.
So I always encourage patients to be honest whenever they can.
Totally.
With their partners.
Yeah, I remember this data in residency, and let me know if you've seen any updated data, but I remember in residency at the VA, they're saying that 50% of men who get penile implant surgery end up not using it. And that's like, then there's other data saying men are very, very happy with their penile implant surgery. But I'm like, if they're not using it at all, like there's such a lost opportunity, and it's a surgery that has risks.
Yeah.
Right.
Yeah. Totally. And that makes me wonder what we were just talking about, right? Like, is it that 50% of the time, if 50% of those men are not using it because their partner has a problem, right?
Yeah.
Like, clearly they, I would assume most of those cases, it's a functional device, right? I don't think they're not using it because it's not working. They're not using it because something's going on with the partner.
Yeah, totally. I mean, I was just looking at this data today. It was 1 million women go into menopause every year in this country. I've seen some data as high as 2 million, so somewhere between that. And then 1 million men get prescriptions for Viagra. And I'm like, that's a very matched numbers. Like, even if we're rounding up, is like, and how many, if 1 million men are getting Viagra prescriptions a year and 90% of them are heterosexual, how many of the women are actually being addressed?
Right. I was going to say, it sounds like a recipe for disaster, quite honest.
I just found it. It's very hard to get data on divorce, like reasons for divorce, because you don't go to to the judge and be like, because they won't sleep with me, right? So it's not it's hard to measure this. But I just read, because I was giving a talk, 1/3 of divorces are due to not having sex and lack of intimacy.
That doesn't surprise me. Yeah,
it's a huge number.
Yeah,
huge number. Let's talk about the data between maybe just the difference to educate people, but the difference between erectile dysfunction and libido in men and how they're correlated, but how they're different. And then we'll talk about the role of testosterone in helping both of those.
Yeah. So erectile dysfunction, simply put, is the inability to get or maintain an erection to complete sexual activity, right? There is a close correlation between erectile dysfunction and libido in men. As an example, in the Viagra trials, men reported an improvement in their erections, but also reported improvements in desire as well. Not because there's some direct impact from the PDE5 inhibitor on their desire, but if someone feels more confident about their erections, gets better erections, they're just going to want to have sex more. And we see similar effects like that in, the various metrics of the female sexual function index too, right? Like you help improve pain for someone, suddenly their arousal gets better, their orgasm metric goes up, their sexual satisfaction goes up. You know what I mean? So there's, it's all kind of linked. But they are technically two separate potential problems, right? A man can have erectile dysfunction and still have a totally intact and healthy libido. And that can be a very frustrating experience for him because he wants to have sex, but is incapable of physically doing that. And then vice versa. I've seen men who have totally normal erections and have no desire at all. And that's where things like testosterone can be helpful because it can help improve both of those issues. But libido, as you know, and I'm sure you've talked about plenty of times on the podcast related to women, is a complicated thing. It's rarely, I should say, just fix erections, libido is magically fixed, or fix pain, libido is magically fixed, right? It's you got to take into account a lot of different factors, relationship factors, hormonal stuff, like psychological stuff. Like there's a lot to consider. But that's part of the fun.
I would say for the sex med experts, we're like, let's figure it out, And for like even for the average, I'd say hormone expert, because they're like, I gave her testosterone, her desire's not better.
Right.
And it's like, go back to the basics. Like there's a lot more. Hormones are incredibly important. But like there's a lot. It's not 1-to-1 linear. Just get to this testosterone level and everybody's going to have a raging libido. It doesn't work that way. Humans are complicated. So I'm interested in your opinion. We're talking more about testosterone and overall health. I think that with what's the name of the big male testosterone study that just came out that said it was like so safe. Traverse.
What?
The
Yes,
Traverse trial
Traverse.
just
Thank
came
you.
out. And so it's like, we know the role of testosterone, or that low testosterone in men, linked with dementia, linked with diabetes, linked with heart disease, linked with bone health. It's like, at what year do you think we're actually going to start screening men for low testosterone as a standard in this country?
Good question. I mean, there's
like, why isn't that a good idea? Like, why aren't we doing that?
I don't know. I think testosterone, estradiol, progesterone get lumped into this weird sex category.
Yeah.
You know, that we just think of those hormones as being important for sex and reproduction. That's it. And clearly you and I both know that that is not true, that all of those hormones serve very important functions unrelated to sex and reproduction. Because I always, when I put someone on testosterone and I'm counseling them on the potential risks and the benefits and how we're going to monitor them going forward, I always see them back 6 weeks later. And I tell them, listen, I'm not writing you a prescription and going to see you in a year, right? Like, there may be dose adjustment that we have to do. We want to make sure that, like, our goals for your testosterone level are also correlating with symptom improvement, right? Like, and we are going to treat this as an endocrinologist would treat any other hormone problem, right? No one would ever put you on Synthroid and say, "Oh, good luck," slap you on the back. We'll see you in a year. There's adjustments that have to be made. For whatever reason, we just treat these hormones differently. So I think, number one, realizing that and thinking of them more as just like any other hormone, I think that it's going to take that. Number two,
like, it needs a rebranding.
Yeah, and making it not a controlled substance that is difficult to prescribe is another barrier that needs to be overcome, so that not just men, but women can have better access to this medication.
Yeah, it's absolutely insane that, like, the Olympic doping scandals of the 80s, and, like, I'm like, East Germany doesn't exist anymore, so our steroid doping regulations can also be updated. And like,
when I realized that like, I guess, like, when you go through medicine, right? Like, a lot of things that we just know to be true, you kind of just always assume have always been that way, right? Like, even the way that we learned about hormone replacement in our medical education, right? I always thought HRT gives women cancer and kills them.
Yep.
And just assumed that it was kind of always like that. And then you read about the pre-WHI world.
The 90s, it's like the freaking Twilight Zone. I'm like, did you know there was a time when 40% of women were on hormones, and it was the 5th best-selling drug in America? It's called the 90s.
I know. Yeah. So when I learned about when testosterone became a controlled substance in the way that we think of it now, I was like, wait, that happened in my lifetime? What do you mean? Yeah.
Right. Because of East Germany?
It's crazy.
It's totally really crazy. Because we were in a Cold War and we pissed because we were pissed we lost some gold medals. Like, and furthermore, testosterone will not make, after I talk to people, I'm like, testosterone will not make you win a gold medal. Like, it's not that powerful.
No, it turns out they have to train a lot.
Yeah. You have to be a genetic anomaly.
Right.
Give up your entire life to train for something.
Right.
And do it, and then rinse and repeat for 20 years, and then you'll win a gold medal. But yeah, like, it's created, like, in the Anti-Doping Act of 1991, the FDA and the DEA didn't want to regulate testosterone. Congress did it.
Yeah.
And so it's like, dude, the people who regulate didn't think testosterone was dangerous enough to be regulated. Right. It just and it's the only naturally occurring hormone on the list. Everything else is synthetic, which to me, I'm like, that's performance enhancing. Like, that's not what the average person wants. So the regulation doesn't reflect what the healthcare of 300 million people need.
Right.
Which is access. Yeah. And especially with how telehealth is under threat for restricted medications right now, of like, testosterone is going to be possibly taken away from telehealth if that goes through. We need it off of the deregulation, or we need it deregulated to be, and people are like, does that mean over the counter? I'm like, no. If you want over the counter testosterone, go to Mexico. They have that there. They have that in the airport. Yeah. You could get it with a cheeseburger. But that's like, I think everything's made up.
Yeah. And I think, getting back to your question, like, how we're not going to screen people for testosterone deficiency if, we can't even prescribe it to them, right? Like that's not going to be part of our screen for diabetes, screen for cholesterol, we're not going to do that until that step happens, I think.
Yeah, that's a good point. Yeah, because I think the stigma for a lot of doctors is it's because it's a Schedule III med that it's addictive. It's not. That it is dangerous. Physiologic levels, it's not. What else? What other stigmas do I see with testosterone? That it'll turn you into a man is the big one with females.
Oh, for women, yeah.
Yeah.
My voice is going to change. I'm going to get chest hair, and
because they don't know ovaries make this.
Right.
And right. I mean, Google says testosterone is the male sex hormone. Sentence right on Google. So we're like, if Google's wrong.
Do you know anybody at Google? Write them. Excuse me.
The podcast is very powerful manifesting energy, just so you know. So
yeah. All right. Well, if any of
deregulation,
the tech bros Google. At Google are listening to this, take that off.
There you go. I mean, the other interesting thing about testosterone, I think, for men and for women is what they're like, and symptomatic, right? And it's like, well, dude, diabetes isn't symptomatic. Bone health isn't symptomatic. Cardiovascular health isn't. These are all silent things. Yeah. So to me, I'm like, I think at some point, the conversation about, especially as Gen X and the millennials start taking the conversation of not just longevity, but like, I want to age differently than my parents.
Yeah.
I don't want to go down like that. I don't want to be frail for 10 years and lose all of my money in home care. Like, it's very expensive to be very frail.
Cognitive function? Just cognitive function, right? Like the importance of hormone health and just being able to continue to think and remember. And, people are always terrified of getting Alzheimer's and dementia. It's like, I'm not saying that we should be prescribing these things to prevent those things. But what I'm saying is there's a clear link between circulating hormone levels and cognitive decline.
Yeah, 100%. I'm like, dude, there's testosterone receptors in the brain of all genders. If I had $1 for everybody who said you can't use hormones for mood, and I'm like, tell me anything, like even antidepressants. Nothing's FDA approved for quote unquote mood. Like mood is very vague. But what is more fulfilling as a doctor for a patient to come back and say, I feel like myself again.
It's crazy.
It's the best thing in the world.
I've seen patients who have been on SSRIs for years and they finally, develop erectile dysfunction. So they end up in my office and I check their testosterone levels and they're really low. I put them back on it. And I've seen these people be able to get off of their psych meds.
I've seen that too.
Because it's just, it's remarkable.
Yeah, it's remarkable. It's like mood is vague. Feeling like yourself is vague. You're never like, are you going to wait around for the FDA to approve testosterone for feeling more like yourself? Like, it's never going to happen.
Right.
But it's like, that's a very important thing for people.
Yeah.
And I think to downplay that, to be like, you can't use it for mood or for the other things, energy. It's never going to be FDA approved for energy.
Right.
But like, how many people come back and can say like, I can actually work out now?
Yeah. What about just motivation? And I'm not talking about like motivation to go to the gym. Like I've heard patients say, I feel motivated to get out of bed now, or I feel motivated to like do things that bring me joy in my life now. You know what I mean?
Yeah.
That's a very vague concept too, right? Like how do you define feeling motivated, right? But when you are not motivated and then you become motivated, there's a big discrepancy there. You feel that change.
Dude, I was just at this conference and this woman came up, older, postmenopausal by many years. And she's like, I got on testosterone because of you. And she's like, now I have a boyfriend. I've started 2 companies. I can now play it on the ground with my grandchildren. Yeah. She's like, this is the best life that I could possibly be living.
Yeah.
And it's like, I can't sit around and wait for, our medical system to care about your life.
Yeah.
Like, I want to treat the person who's sitting in front of me. And so we have to do things off label.
I have that reminds me of a female patient that I had early in my career who was also, I think, like in her mid 70s at the time. And again, going back to this like lack of motivation, no energy, she was like, I can't play with my grandkids. Like they come over and they want grandma to play basketball with them or do things with them around the house. And sure enough, I put her on testosterone and she was just like, it's changed my life. Like I can play with my grandkids. I can be a grandmother to them. So yeah, I mean, it's crazy.
I mean, I think the other reason reason number 12 that I want to deregulate testosterone is so that testosterone, to me, like, it's just a tool. The rest of your health needs to be managed, but you need to be followed. Levels need to be checked. And I want mainstream medicine to take this on for people, because otherwise they are pushed to maybe less scrupulous people, or, you know, online where you're never going to get care. Like, I want the good care that can happen in mainstream medicine, because people are looking for energy, motivation, improvement in quality of life, and they're going to go outside to get it. And I think that's probably not as good healthcare.
Yeah, I think, unfortunately, I was talking to Suzanne about this last night. The way things currently
Suzanne
exist.
Gilbert Lenz, we love you. We're shouting out to you.
Shout out. We do love Suzanne. I was saying that, unfortunately, the way things currently exist, it's like you hear these stories from patients where they're either told, get off your hormones, you're gonna die, or get cancer. Or they end up in these like hormone mills where they're getting these like pellets inserted in them and developing all kinds of side effects, and then coming to us to fix the problem. And I'm just like, there has to be a medium besides me and you that can help these people, so that they're not at these two extremes, right? Like there's real sort of evidence-based approaches to these problems that we can employ.
Yeah, I love it. I think you said that very well. It's like, it's all or nothing, or not all or nothing, but like harmful or harmful. And in the middle, in the middle is where the good medicine is. I had this woman message me last week, and she's like, my doctor said I'm too old for hormones now, so I need to stop them. And I'm like, how old are you? She's like, 73. And I'm like, what other medication? Or do we tell people like we're not going to manage your diabetes anymore because you're 73?
Right. Give me your insulin. Give me your insulin.
Like, like you don't need thyroid anymore because you're 73. The other, I'm just gonna, like, because I'm feisty, I've made the comparison about like GLP-1s. It's a hormone, because again, it's the stigma of this freaking hormone, right? GLP-1s are hormones. They're modified so they actually last longer than the GLP-1 in your body, right? And so we're not even saying your GLP-1's low. We're just saying we want to give you some more GLP-1 that lasts longer, because it actually does better for you than the GLP-1 you have. Not that we're saying it was low. We just know better is better, right? And so I'm like, and by the way, for GLP-1s, there is more than 100 products in the pipeline.
Oh yeah.
For GLP-1. Sure. 1 in 8 Americans have been on a GLP-1 already. In like
3 years. Yeah.
Yeah. So I'm like, anybody want to call that a bias of hormones?
Right. Like, yeah. But it has nothing to do with sex. So we're good.
Right? Yeah. Watch them. Dude, I'm waiting. Like, this paper will happen. Maybe Goldstein will do it for us. But like, GLP-1s and the role on sexual function. I've seen one paper. This is just a fun tangent to go on. I've seen one paper that said it did not decrease desire in men. It was like a 3-month paper. But because it does decrease your interest in like alcohol, gambling, like dopamine sort of things, I think there will be more papers on it. Have you seen any, I don't want to call it sexual side effects, but like, have you seen anything with GLP-1s and sexual function?
I haven't. If anything, I've seen it help. Okay. I think, and this is just me postulating, but I think when people lose weight, right? Like certainly things happen in their body. Maybe they're getting off blood pressure medications. Maybe their diabetes goes away.
Body
image exactly. People feel more comfortable in their body, and their organs start getting better blood flow. So if anything, I've seen it help people. But I do think that it will be interesting to see in a clinical study setting, taking real metrics, FSFI for women, shim, IIEF for men, like getting real data would be a really interesting thing to look at.
Yeah, I think it'll come. I know they're looking at, so if men are, this is for male population, if men get on GLP-1, the adipose tissue decrease can increase their testosterone. And so it's like you're actually might increase their testosterone by the secondary effect of the GLP-1, which is very cool. And then the second piece of data, they have this in both male and female, is that people who are on hormone replacement, so you're taking testosterone and a GLP-1, you're taking menopause hormones and a GLP-1, you actually lose more weight and preserve more lean body mass. You preserve your muscle better when your air quote sex hormones are at a good level.
Yeah, I mean, that makes a lot of sense. And one of the things that people worry about, especially I would say in the older female population who use these medications, is muscle loss, right? We know how important that is in perimenopause and menopause. And so that I think is going to be a really important component to couple those things together if you have someone in that age group that would benefit from GLP-1s, right? You have to make sure that you're doing whatever you can to preserve their muscle density.
Totally. Yeah. I mean, it'll be interesting to say, like, to see where best practice, because at some point they're going to have best practices for GLP-1s, I think, and to see if they include the sex hormone replacement therapy. I really want to rebrand. I don't want to call it sex hormones anymore. I want to call them brain hormones.
Yeah. Good luck.
You're like, Dr. Gonzalez is like, good luck, Kelly.
I mean,
do you know anybody at Google?
I love the ambition. I would be in like, total
Dr.
favor of that.
The woman who rebranded sex hormones.
Yeah. I mean, listen, so if it could take it, if we could remove coupling those with sex, I think that would be hugely impactful for all the reasons that we talked about earlier. But
yeah, totally.
I don't know. Things are difficult to change in medicine, as you know.
I have some more rapid fire questions as we wrap up, and I'm going to use your word, cock rings. Discuss.
Yeah. Do I like them?
Are you like everybody should experiment with them? They're super wonderful and great. Yeah, pro cock ring.
Yeah. I would say I would say I'm pro cock ring. I have a lot of patients that use them, both for kink and for necessity. Like some guys who have trouble maintaining an erection find it easier to hold on to their erection by using them. The one thing I always tell anybody who asks me about cock rings is please just make sure that they are not metal. Because I've been in the room.
Have you had the experience?
Yes. Not personally having it cut off me, but I've had to cut it off
as a professional.
Someone else. Yes. Let's just say there's a lot of sparks. There's a lot of screaming and pain because of the cutting through the metal that close to very sensitive skin. So I have no problems with cock rings and would encourage people to use them if they find them helpful. Just please make sure it's made of a material that you can easily cut through.
Yes. This is now the point in my podcast where I tell you about me cutting off a cock ring.
I want to hear it.
It was a motorcycle coil.
Ooh.
Automotive grade steel. Wrapped, multiple coils fused together. So it was a good 5 inches long. And the ER doc called and he's like, this guy's had a cock ring, but a motorcycle automotive coil on for about a week.
Oh,
and I'm
God.
I'm at the gym taking this call and I'm like, take it off. he's like, I don't think you understand what is happening. And it had eroded through his shaft skin on one side because he left it on and then he got swollen and then it never came off. So he's just swollen all around it. And so it's fused. So I call the one trauma center in Washington State to get the trauma urology guy. And it was the oncology urology guy taking call. And he's like, I don't know. I called the fire department to be like, hey, I've heard of these jaws of steel. Can you come to the hospital? And they're like, no. And so I'm like, okay.
Really?
Yeah. So then I'm like, this is me being proud of how ingenious I am. So I'm like, okay, I called for help. I called the fire department. What do I do now? And I'm like, I call ortho because they cut through metal rods all the time, right?
Yeah.
So I'm the one squirting because it's sparking and it's steaming. This is under anesthesia because this is legit.
Yeah.
We cut through, also it's like 5 different pieces of metal on one side, right? We cut through it all. We go through every diamond tip drill bit that the hospital has, and you can't open it because it's so fused, right? So we got through a whole side, had no more drills left in the hospital, had to wake them up, get more drills, take them back to the operating room the next day, flip it, go through the entire side, and then pop it off that way.
Yeah,
unless your urologist would have amputated.
Yeah, I was fortunate enough. I was a chief resident, and my junior resident called me. It was at the VA in the Bronx, and same thing. Some guy had, it wasn't a car part, but it was just a traditional metal cock ring. But he fell asleep with it on.
Yeah, don't fall asleep with your cock rings on.
Yeah, got swollen, couldn't get it off, whatever. The fire department came out and was doing it. We were pouring the water. They finally cut through it after the guy was screaming for 30 minutes because we did not do it in the OR. We did it in the ER. And then they're trying to pry it open, but they can't do it. And I just looked at my junior resident, Katie, and I said, it was like 5 a.m. on like a Sunday morning. And I said, you need to go in there, get that off of him now. And she was like, okay. And she like pushes all these big like firemen out of the way. She's like, excuse me, can I just look? And she just goes, whack, and pulled it off. And the guy goes like, and she goes, all right, let's go. And I'm like, all right, come on, we got to go. Yeah. The things that we do in residency.
Sometimes you just need somebody with a little bit of authority, who knows how the people, urologists get very well trained in how hard to pull.
Yes. Yes. And how, I always joke about like how resilient the penis is. It can take a lot of beatings and it'll be okay. So, knowing that, you're like, yeah, I'll just pull the ring off. It'll be fine.
Oh my God. Do not use metal cock rings. Like if I go to a store and I see that there's metal cock rings on the shelf, I'm like, what WTF are you doing? Mostly because I'm like trying to protect the urologist on call, right?
Right.
Don't make more work for us. Same goes for, sounding or putting anything up the urethra. It's got to have a stopper on it.
Please. Yeah.
Got to be able to take that thing back out.
Yeah.
Because we like to sleep instead of work when we're on call.
Yeah. You don't want to have to go to the OR to have like a incision in your perineum to get it out, which is what I've had to do before.
Yeah. Yeah. I had multiple dried beans put in the urethra, and then he just peed over them for like 5 days. So they got swollen. Very difficult to get out.
People are so creative when it comes to sticking things into their orifices.
Yeah, like we have all the pro tips of like, don't, use professional stuff that's made of the right, like people make the right things for this. You don't need to use dried beans. Okay, let's go to pop star and taking something to increase your ejaculatory volume. This is, I've never seen anything like this. Mm-hmm. How did this come about? Tell me everything about it. Oh, good.
It is
good. For our video viewers, we just saw a bottle of Pop Star. I'll put the link in the show notes.
Yeah, so it was a
the name's
project.
Brilliant.
Thank you. It was a idea that I came up with right at the beginning of COVID. I had been thinking about this, and then the pandemic happened, and I didn't see patients for several weeks because everyone was on lockdown. And I just spoke to Brian Steixner, who's another urologist in Jersey, who's kind of always been a mentor of mine. And I was like, hey, what do you do for this problem? I get a lot of guys coming in wishing that they had more volume like they used to when they were younger. And he's like, I don't know. He's like, I don't really see that problem that often. I'm like, well, maybe it's an LA thing. Maybe it's like, because a lot of my patients are gay and that's important to them. I don't know. But I was like, I think we should try to like come up with like a natural solution. So we just kind of put our heads together, looked at what limited data are available. It's mostly in like animal models and a little bit in like the human reproductive literature at ingredients that have been shown to improve either, semen parameters or specifically ejaculatory volume. No one had ever really approached this issue from a pleasure standpoint. Yeah. It always, when we talk about volume in urology, it's always about fertility, right? Volume is an important part of assessing a man's fertility when you're looking at his semen.
Because it makes the semen, it's just more slip and slide for the semen?
Yeah, it's essentially what holds all of the nutrients for the sperm, right?
Okay.
So volume becomes an important predictor of your fertility potential, essentially.
I did not know that. That's very
Yeah.
cool.
So, but we wanted to take a different approach, right? We were looking at men complaining of this problem because the decrease in volume had made sex less pleasurable, or maybe they felt like their orgasms weren't as intense as they used to be when they would, ejaculate more. And so, we put together the formula, kind of launched it as like a pet project. And we're like, oh, let's start this company and launch the supplement. And it's kind of grown to be a full legit company. And we
I'm
have
so
just
proud of you.
Been along for the ride. Yeah, no, it's been really cool. And we're hoping to just continue to, expand the products that we can offer to address like real sexual health, issues that come up in our practice on a daily basis. So yeah, it's exciting.
That's very cool. Have you tried it in men? So like some medications will decrease semen volume. Have you tried it in people who they're on meds that cause that? And is it helping?
Yeah. So I've seen it. I've tried it in my patients who are on Flomax, who have retrograde ejaculation, and will report an increase. It doesn't reverse the retrograde ejaculation, but if you're producing more fluid, you can kind of overcome out.
You can overcome some
exactly.
of it. Yeah.
Exactly. I've seen some guys even who are on testosterone who sometimes will report a decline in their semen volume related to being on testosterone replacement, who will report an increase in their volume as well. So it's been pretty remarkable at like the different groups of people that it's helped, because we have customers and patients of mine who use this who are older, who notice a big difference, and then we have even guys who are younger who use it more as like a tool to just improve their sex life and get more powerful orgasms. They may not necessarily have like a deficiency, but they just want more. And so it's kind of cool that
I have more questions now. Why does the semen volume go down naturally with age?
That's a good question. I think it's related to a decline in hormone therapy, although we do see declines in volume with testosterone replacement as well. So
that'll be interesting. That'll be interesting with the new oral Kysotrex meds, because they are not supposed to. We still need more data, but the theory is less sperm issues, because with the injections and transdermal, infertility and low sperm count is just a kind of, I would say, natural side effect. It's not a side effect; it's a known. What would I say? It's a not a benefit. It's what happens. It's not a side effect. It's just what happens.
You're suppressing your testicular function, right? That includes production of testosterone, which is probably already low. That's why you're on testosterone replacement, and sperm production.
And so if the oral testosterone doesn't affect sperm production, it might not affect semen production. Is maybe the
That's
theory?
true. Although sperm is only about 10% of semen. So
I'm sure that's the first thing they'll study: semen volume with this medication.
Exactly. But I mean, I think along those lines, the oral testosterones, Kysotrex, another big complaint that I don't know if you've seen this in your patients, but the effect that happens to men also is they have testicular atrophy, right? Their balls shrink. Which, if you're a guy in his 60s, maybe that's not something that bothers you as much. But if you're a younger man who, that can be something that bothers people. And so we don't really see that with the oral testosterones because they're shorter acting. So you're not getting a consistent suppression of testicular function, and therefore have less atrophy.
Interesting. Can you explain for people too? So we already broke down libido versus erections, but I think it's important to say that ejaculation and orgasm is yet another different part of the male sexual response. But the feeling of semen moving through the urethra is very pleasurable.
Yes.
Explain it to us as if we don't have penises. So that's because I think a woman would be like, why are you going to take something to make you come more? Like it's just messy, and you're making it messier. Help me understand.
Yeah. The way I explain it to people, the way we think, of course, this has never been studied, but the way that we think it has a positive effect on orgasms, right, is if you're producing more fluid, you are going to require more contractions, pelvic contractions, to expel that fluid. One of the components of the pleasurable experience of orgasm for men is that contraction feeling, the pulsations, right? The spasming that you're having. So if you are prolonging that experience because you have to expel more fluid, then it can make your orgasms feel longer and more intense.
How does the pelvis know there's more fluid to expel?
It's just got to get it. It's in the that I don't know. That I don't know how specifically it knows that the fluid is in the urethra and it's got to get out. But
in your experience, people are like, it's not just that the volume's bigger, it's that the actual force of the experience is more intense.
Yes. Yeah. And I mean, depending on the person, there are some people that just like a lot of cum, you know what I mean? And like, they find it like kinky and enjoy it.
It's pleasing to them.
So exactly. So that can also add another layer of pleasure to the experience.
What has happened when a vulva owner has taken the supplement?
I don't know.
Shall I give you my address after this podcast for some free samples?
We'd be happy to send you a bottle. Yeah.
Well, we gotta experiment, Dr. Gonzalez.
Well, also it's a taste enhancer. It's a taste enhancer too. So it not only increases volume, but it
what, you put asparagus in there or
No. Asparagus would make it taste not great. There is bromelain in it though. So, which is that pineapple extract.
And that is because we know that people who eat pineapple have more pleasurably tasting semen. So,
shockingly, there have not been any studies on taste because I'm not sure that would ever pass the muster of an IRB. But yes, anecdotally, right, you hear stories about like, if somebody has funky spunk or whatever, tell them to eat a bunch of pineapple. So that's where the thought process behind that. And then we also added some fructose to it. Whatever you are consuming and digesting is going to be excreted one way or the other. So we know that some of that will end up in the semen.
I literally am doing this podcast for my education at this point. I love it. This is so fascinating. Can we talk about one more thing before we wrap it up?
Yes. Yeah.
Tell us what fallofill is. I have not talked about this on the podcast, and people need to know what's happening.
Yeah. So fallofill is a procedure where we inject hyaluronic acid filler. So people have probably heard about fillers elsewhere in the body, in the face, and the lips, right? To add volume. Exactly. So it is a safe and effective way to increase the size of the penis. It's a primarily girth enhancing treatment, so it makes your penis thicker. But one of the secondary benefits,
just when flaccid?
No, it translates to erect.
It translates to erect. Okay. Unlike the implant, because the implant is, what's the name of the implant that goes around the shaft?
I think it's undergoing like a brand change.
Okay.
But it used to be called Pneuma. I'm not sure that it's called that anymore.
Okay, so there's a surgery where you underneath the skin of the shaft you can implant like
it's a silicone device.
Thank you. I'm like, what's the best way to describe this?
It's like a sheath.
It's a sheath. Circumferentially all the way around?
I think it doesn't go over the urethra, so it looks like it looks like this, and then it goes like that.
Got it.
Yeah. So it's got like a hinge in the middle.
And that's more flaccid than erect, is what I've heard. Looks bigger, flaccid, but not erect. Okay.
Exactly. And the
hyaluronic acid does both.
Yes, for girth enhancement, you'll get a girth increase, both flaccid and erect. The cool thing about it, which I did not expect when I first started doing the treatment, is that it also helps with flaccid length. Because of the volume that it adds, it reduces the degree of retraction that a lot of men have in the flaccid state. So I had a lot of patients coming back to me saying that they felt way more confident walking around naked in the locker room, if they're wearing, briefs or Speedos, filling out their underwear or Speedos more. So that was kind of a cool secondary benefit that I didn't expect, that they were just feeling more confident because of the way it hung in its natural state.
What about the men who they've gained weight in the middle and their penis kind of subsequently? I always tell guys, tell me if I'm wrong. I tell guys, like, the penis stays the same length because it's attached to the pubic bone. You got bigger around it. So,
Yes.
so it's an optical illusion that the penis is smaller. It's just that the human is bigger.
Yes,
and did I get that right? And
no, you're correct. And people do get atrophy. So as we age, your penis is going to be smaller when you're 60 than it was when you're 18. That is a fact of life. You can do things to try to offset that as much as possible, right? Like if you do things that are pro cardiovascular health and allow, a good, healthy amount of blood to circulate into that area on a regular basis, you're going to prevent atrophy as much as possible. So I would say you do have some shrinkage from natural atrophy that occurs with age. And also when you are overweight or obese, and especially if you carry a lot of weight in that suprapubic fat area, then yes, there can be a burying of the penis. And if those men lose weight, or sometimes if they, I've even seen guys who have had lipectomies where they take out that suprapubic fat pad, you restore the length of the penis, which was there all along. It was just sort of being buried in the fat.
Very interesting. Have you heard any men say that when they got back on testosterone that they noticed their penis got bigger? Because I just think blood flow.
Yeah, I don't know. I mean, I
it's not
think
a common thing that I've heard. I
can't think of somebody that has specifically said that. The reality is that depending on how long you've been letting atrophy go on, it's not the easiest thing. It's not something that can necessarily be reversed, right? So it's all about, as with many things we talk about in health, we should start talking about prevention.
Prevention's better.
This?
Yeah.
Yeah.
I think the same with clitoral atrophy.
Totally. Yeah.
Totally. Well, like women come in and they're like, I think vaginal estrogen should just be, first of all, over the counter, which is probably not going to happen. I think we're going to deregulate testosterone before we're going to get vaginal estrogen over the counter. But really, skincare for down there is like, why not just start at age 50, 55 before you come back and be like, you don't have labia or much of a clitoris anymore.
I mean, you could even make the argument earlier, right? I mean, I've seen women who are on oral contraceptive pills who have significant genital atrophy, you know what I mean?
Yeah.
And
Absolutely.
that would benefit from vaginal estrogen. So, I think that there's millions and millions of women who would benefit from it.
Let's talk about the I don't know, the elephant in the room is the wrong word, but like, I think a lot of women listening are going to be like, why do men want their penis to be bigger? We don't care. We know it doesn't matter as far as female sexual pleasure. Are men just being extra, orgasming 92% of the time? Like, you guys already have better sex than women do. So like, explain to like maybe a listener who's kind of coming from that, of like their lack of understanding that like, isn't your sex already good? And we don't care about big dicks. Like, what are you doing? Why aren't you just buying us a nice? Why aren't you just buying us a nice dinner instead?
Yes. So what I would say is a majority of the men that I see that are exploring or seeking out enhancement procedures, right? Size increasing treatments like Falafel, have normal size penises. I mean, I see them, I examine them, they fall within the normal range, right? I equate it similarly with other types of cosmetic procedures, right? So breast implants in women.
Breast implants.
Most women that get breast implants have normal size breasts, right? But for reasons that, are unique to them, have always felt some sort of insecurity about their breast size. They undergo these surgical procedures, they feel more confident, they start, enjoying sometimes sex more because they feel more confident about their body. And it's very similar to that. So even though they may be starting from, a normal size penis, and we're not making them, they're not switching careers to be porn stars all of a sudden, right? They just want to feel more confident in bed. Maybe that's because a partner made some comment before, but sometimes it's just something that they carry internally. And I've seen it really have a profound impact on men's self-confidence, which then translates to an improved sex life. I've actually seen female partners send men back in to get more. They do their initial treatment, they go home, they test out their new penis, and then they come back into my office and want to get more added. And I say, oh, what brings you back? Oh, my wife like loved it. You know, she was like really hesitant at the beginning. She told me, don't do it. I love your penis. It's fine. It's perfectly sized for me. And then I think some of that self-confidence translates to the partner.
Yeah.
Because that self-confidence translates to better sex with the couple.
Yep.
And they're like, I see how much it's affecting you in a positive way. I love this for you. I want you to continue to feel like this. Let's get you another round. You know what I mean? So
I love that. I love that. And thank you for sharing that perspective, because I think we've really normalized breast augmentation's been around for decades, right? So it's really been normalized. And then when men say, hey, you know what? We've got body confidence issues too. Like we're not unique. It's the exact same. And really to normalize like, yeah, that this is just new. And I think it's going to take a while to destigmatize that. But when you say like women have been getting breast augments, like no questions asked for a very long time, and really to help support men, you know, they have insecurities too, and it's not just they're not doing it just for their partner, they're doing it for themselves.
Right. And this is not a surgical procedure, right? Like, I mean, you could even argue that this is
the push-up bra.
Exactly. I love that. I love that. I haven't thought of it that way. But yeah, I mean, that's why I always encourage patients to pursue something like this as opposed to undergoing some surgical procedure, right? Because there are complications with surgery. There's infections. There's you can damage the nerves. You know, all of these sorts of things. Hyaluronic acid filler is incredibly safe. It is reversible. Should someone have an area that they had treated that they don't like, we can dissolve the filler. So it's really carries very little risk and can make a pretty profound impact on their sex life.
How long does it last?
On average, about 2 to 3 years, but we're finding in some patients it lasts longer. It seems to break down slower than it does elsewhere in the body, because usually people who do, you know, face and lip stuff are having to get it done more frequently than that.
Yeah. Any worry with scarring, or is it just not enough injection? It's like scarring.
Well, we're putting the filler kind of between the two fascial layers. So there's not really, like, we're not really running the risk, assuming that they're going to somebody like myself or who is familiar with the anatomy. There should be no risk of scar tissue done to the corpora. So we kind of create a plane between those two fascial layers by hydrodissecting using lidocaine, and then we put the filler in that area.
Perfect. And I think this is why it's so important to go to somebody who's trained, who, like, for example, is a urologist, who's done a sex med fellowship, because there's some, and I don't want to stereotype, but I'm hearing it more from my Southern California urologists, that men are coming in, side effects from, like, in your garage, some dude injected something, like, so it's really like back alley augment stuff that has like horrific side effects.
Yeah, I mean, this is really the wild west as well. Like, there are people doing, you know, medical grade silicone, sometimes not medical grade silicone. There are some other synthetic fillers that people are using, these collagen stimulating fillers that are permanent, that sound very attractive. You're like, oh, why would I not want a permanent solution, right? The problem is that permanent means permanent. If there is an area that looks a little uneven, guess what? You can't fix that. So I, you know, always encourage patients to avoid those permanent fillers or those synthetic fillers, even though they sound appealing. I would rather do these treatments every few years for you and be able to manage some potential, you know, asymmetry with a little Hylenex than to do a permanent filler in you that, you know, has some migration that we have to then operate to remove.
Totally. I'm like, in my head, I'm like, obviously, but I don't think it is obvious. You know, like, some people want, they don't think of the nuances of what permanent means.
Yeah, exactly.
I love it. And just to clarify, but our insurance is not covering cosmetic penile procedures at this point.
That's right. Yeah.
Okay.
Yeah.
I have one more testosterone question, and thank you so much for your time. There's some data on people who take statins for high cholesterol, that because it lowers cholesterol, and cholesterol is what is needed to produce testosterone. There's some papers that show a lowering of testosterone on statins, but it's not below what is considered normal on labs. Now,
Mm-hmm.
I would argue normal on labs goes down to 300.
Yeah.
And so my question to you is, have you seen that clinically significant, and or why not recommend checking testosterone in people who are on statins?
So I haven't seen that clinically, but it's interesting that you bring up statins because I just had a conversation today with another provider who referred a patient um, for ED and low libido who had low T. We corrected that issue, was actually doing quite well from an ED and libido perspective. Got started on finasteride and a statin at the same time. Then complained to his primary that his libido went down. We redid his blood work. His DHT had lowered because of the finasteride. We told him to get off of that. He did. Still on the statin. They switched the statin. His libido has improved some, but has not gone back to what it was when we first put him on hormone therapy. So I don't know. And numerically haven't really seen that much change in his testosterone numbers, but it was the first time I was like, I never really thought of statins as like a libido causing medication or a low libido causing medication. And I'm going to have to, this just came up today. I'm going to have to like look at the data and see if that has been reported, but I was not familiar with that.
Yeah.
So,
I haven't looked at statins and libido. I've looked at statins lowering testosterone.
Yeah. Yeah. But we have him on testosterone,
right.
We had him on it even before. So I don't know.
It's tough with the finasteride being in there though.
Well, that stopped. We got him off that.
Good. But some post-finasteride syndrome is permanent for some people.
Yes. Thankfully, he was on it for like a few weeks and then he saw us and I was like, we need to get you off of it. Yeah. I have seen post-finasteride syndrome even with like very, very short exposure. Thankfully, it seems like he is not in that category.
Yeah.
But
it's interesting in the women. Again, it's like these Venn diagrams, right? Like a lot of hormone experts aren't sex med experts. And so to like the unique, like, the people of us who are, we think about these things. So I saw a lot of women who are going on testosterone, especially if they're being put on higher dose, they're having hair loss. So then they're giving them finasteride for the hair loss. And I'm like, but the sexual function.
Right. So, right.
So I think it's like the Wild West over there, because especially if it's a gynecologist doing all this, they don't know about the finasteride in the men and like how some, not everybody, can have pretty bad sexual dysfunction from finasteride.
Well, yes. And I would say some of the sadder stories, post-finasteride stories that I've seen are not even sex. They're cognitive, right? There's like reports of people feeling depressed, having suicidal ideation. There's even been cases of suicide related to finasteride use.
Are you saying
people
that
will describe like, go ahead.
I know I don't want to make fun of something, but I just want to emphasize for anybody who doesn't get it that these are brain hormones. Right? Yeah. You're like, look what happens when you block them.
One of the biggest complaints that I get in post-finasteride patients is brain fog. Like I just wake up and I just can't find words and I don't remember things and I'm not as quick as I used to be or sharp as I used to be. And that's the stuff that's really hard to fix.
Can you push the testosterone up, or what do you do?
Sometimes, yeah. I mean, that's one thing that we try to do, and just hope that it gets better over time. But it's challenging. I mean, it's also a weird syndrome that we don't really know that much about. So it's a lot of it's sort of experiment, trying to undo the problems that arose from taking this medication.
I mean, I feel like at least now more men are being believed. Because I think a couple of years ago we're like, it's not a problem.
Yeah. But because I mean, the finasteride story is a story of old men, right? Like we initially used it as a prostate medication, right? So no one talked to like 70-year-old guys about like whether or not they were still getting boners or like had a decrease in desire or their cognitive decline was just because they were in their 70s, right? But it wasn't really until the medicine got rebranded and lowered the milligram dose to Propecia, where we started seeing young men using it for hair loss prevention. And suddenly you have these young, totally normal sexual functioning guys being like, wait a minute, like I can't get an erection anymore, or like I don't want to have sex anymore, or I can't get my schoolwork done because I can't concentrate anymore. So yeah,
not benign by any means.
Yeah.
So nice to chat with you.
Yeah, this was fun.
Can you tell us where people can find you for
Yes,
all of
I
all of
am.
your expertise, technical and otherwise?
Yeah, I'm on Instagram and TikTok at Joshua Gonzalez MD. My website is the same, joshuagonzalezmd.com. And
Are
that's
you still
primarily where I
dancing?
live.
Are you still dancing as much on Instagram as you used to be?
I
It's
try
not feeding it
to.
to me lately.
I try to do some dancing. Yeah, I try to switch it up, try to have a little fun with it.
I love
Yeah,
it.
got to keep people on their toes.
Totally. JoshuaGonzalezMD.com. And then what's the website for the pop star?
Popstarlabs.com.
I love it. Okay. Thank you
Yeah.
for joining me. This has been a wild ride, and I think people are going to
Yeah, it's
enjoy
fun.
it. Cool. Thank
Good.
you. Bye
Good.
bye.
Of course. Bye.